Hi, this is Tom Charlton. I'm the Regional Director of EMS for U.S. Acute Care Solutions here in the Cincinnati market. And I'm going to talk to you today about EMTALA, or the Emergency Medical Treatment and Active Labor Act, which came about and impacts EMS. So we're going to describe the background of where EMTALA came from and what role it has on hospitals, and then also kind of the consequences of not adhering to EMTALA. We're also going to talk about what EMTALA does not require, and then we're going to have some specific situations. When I do this presentation live, there's usually a fairly robust question and answer session. At the end of the lecture, you will see that I have my QR code and email address listed there. If you scan the QR code with your phone, that will give you my cell phone number as well as email address straight into your contact list, so that you can call me or email me with any questions you might have. So this is one of the cartoons that I found regarding EMTALA, and it really hits home. If anybody remembers during, I believe it was the 2012 presidential election cycle, Mitt Romney, I think during one of the debates, made a comment that, everybody already has universal health care. It's called the emergency department. And the reason that comment hit home is obviously I'm an emergency physician, and so I bear the brunt of that. But it really kind of is true, and it's one of the things that I actually like about emergency medicine. Anybody that shows up to the hospital who needs help, I'm going to help them. I don't really care about what their insurance status is. I don't care about what their demographics are, anything like that. You show up to the emergency department, and I'm going to help you. And part of the reason for that is because of the law that we're going to talk about today. Now, the problem is that nobody really pays for it, except we all pay for it with higher healthcare costs and higher health insurance premiums. But overall, I think the law has been good for society. So the background of this is this was signed into law in 1986. It's an anti-dumping law, essentially, is what it came about as. So what had happened is in the late 70s, early 80s in the Chicago area, there was significant competition among multiple hospitals. And keep in mind, this was primarily before the consolidation of hospital systems like we have today. So you would have hospitals that were all vying for, the insured patient and not really wanting to take care of the uninsured patient. There was no law that prohibited, one hospital from essentially putting patients in a taxi cab or in an ambulance and simply sending them to their competition across town. And so what happened is the hospitals would literally start doing that. They would have somebody who showed up to the emergency department, didn't have insurance, and rather than evaluating them and then arranging for their care, they literally would call a taxi, send them across town to their neighboring hospital, who might turn around and do the exact same thing. And so in the end, the patient was the one who was getting harmed. They weren't getting the care they needed. They weren't receiving the stabilizing treatment that they needed. And frankly, they had, several instances where either the patient or unborn child or infant ended up getting hurt as a result. You'd have, someone who didn't have OB care, who was actively laboring, and rather than just simply taking care of the mom and child, the hospital would dump them on another hospital. So obviously, because this was occurring, something needed to be done. It wasn't just Chicago where stuff like this was happening. It's just those were kind of the instances that really got everybody's attention about it. And so the feds passed this legislation that essentially says that you can't do that. It only applies to hospitals that participate in Medicare, which is at this point the vast majority of hospitals. There are very few private hospitals that don't participate in Medicare. However, it's an unfunded federal mandate. So what this means is that even though the patient is uninsured, nobody is obligated to pay for that care. The hospital essentially has to eat that cost. And so the way the hospital has to get around that is by increasing the costs for everybody else. That's why if you look at cash prices for all the various procedures and medications, et cetera, that's why they're astronomical. Nobody ever pays that, for the most part. But that's why the cash cost is that high, because then the insurance companies turn around and negotiate a 50% cut off of the cash price. So the numbers are all essentially gamed so that the hospital is able to essentially pay for this unfunded care, by essentially charging everybody else more for it. So Mitt Romney was to a certain extent correct. Anybody that comes to the emergency department is going to get care, and they're going to get admitted and stabilized if they need more care. But the problem is that we're all paying for it, and instead of this being a direct benefit to the hospital, instead we have the insurance companies making money off of that increased cost of care. So there's obviously lots of issues with EMTALA, and you can definitely tell as we get further along that this law is kind of aging and probably is in need of some either clarification, if not a complete rewrite. So one of the requirements for EMTALA to kick into place is that you've got to have an emergency medical condition. And I hate reading from slides, but this is literally the definition of an emergency medical condition according to the feds. And it says it's a condition manifesting itself by acute symptoms of sufficient severity, including severe pain, such that the absence of immediate medical attention could reasonably be expected to result in placing the individual's health or the health of an unborn child in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of bodily organs. And part of the thing that's implied within this is this thing called the prudent layperson standard, which means that if the average person believes that what they have is an emergency medical condition, then it's an emergency medical condition. We don't expect patients to be able to diagnose themselves as just having strep throat. We don't want them to, avoid coming to the emergency department with their peritonsillar abscess because they're worried that they may not get their health care covered by their insurance. And there are insurance companies that over the years have tried to kind of buck this trend of saying that retroactively, if you go in with a sore throat and it turns out that it's actually just strep throat, that we're not going to pay for it. And those provisions that insurance companies have tried to monkey around with have always not borne out in court. And the court continues to reinforce this prudent layperson standard. For those of us that are trained, which is the vast majority of you guys, listening to this lecture, et cetera, we are not prudent lay people. We are medical professionals. And so what to us may not seem like an emergency is partially clouded by the fact that we've been trained in how to determine what's a medical emergency. Even in the best of cases, physicians are not even all that great without additional testing at really truly determining whether an emergency medical condition exists or not. That's one of the reasons why, we do blood work and we do pictures and we do IVs and we give you medicines and sometimes we admit you to the hospital. It's because we're trying to make sure that there isn't an emergency medical condition. So this all applies to hospitals that have an emergency department or that hold themselves out as being able to provide emergency care. So, of course, the feds have another definition. An emergency department is a specially equipped and staffed area of the hospital used a significant portion of the time for initial evaluation and treatment of outpatients for emergency medical conditions. So, we don't really have any of these hospitals here in the greater Cincinnati area, but there are specialty hospitals like up in the Columbus area. There used to be a specialty heart hospital where essentially all they dealt with was heart patients, congestive heart failure, heart attack, things like that. They did not have an emergency department. They essentially would be either direct admissions from cardiologist's office, or they would be transfers in from other hospitals. But they did not have an emergency department. And so as a result, even if they are accepting Medicare dollars, they are not bound by EMTALA if a patient presents there wanting to get care. Now, obviously, if the patient is being transferred in as a result of an EMTALA-related emergency department visit or hospitalization, then EMTALA does apply. But anybody that shows up to their front desk and says, "Hey, I sprained my ankle, I need care," they're not under the obligation of treating that patient by law because they don't have an ER and they're not holding themselves out as being able to assess people for emergency medical conditions. The same kind of thing applies to a psychiatric hospital. We do have several of those in the area. And if you show up to one of those, same complaint, I've sprained my ankle, etc., they're not under obligation to see you unless they hold themselves out as being open to emergencies, etc. None in the area that I'm aware of do this, but theoretically, if you have a psychiatric emergency department like the PES down at University of Cincinnati, if somebody shows up there with a medical complaint, not a psychiatric complaint, they are, going to essentially send that patient, across the street over to the main emergency department so that they can get their medical screening examination and determine whether or not an emergency medical condition actually exists. So I just used the phrase medical screening examination because that's what's written into the law as well. And essentially, this is an exam that has to be performed on anybody that shows up to the emergency department asking for care. And it's got to be thorough enough to determine whether an emergency medical condition exists. And so, for sometimes it's just simply I lay eyes on you, I talk to you, I do a physical exam on you, etc. And that's enough of an exam for me to basically be able to rule out whether or not an emergency medical condition exists. However, sometimes that medical screening examination isn't complete by the time they're ready to leave the emergency department. We need to admit them or transfer them to another facility to determine whether or not an emergency medical condition exists. A prime example of this that happens every day is chest pain. If we have somebody that comes in with chest pain, we may not be able to determine in the emergency department completely whether or not they're getting ready to have something happen with their heart, and so we need to admit them to the hospital. That way, the cardiologist can see them. They can potentially have additional testing, like a stress test, done, and then determine whether or not this person is actually getting ready to have something bad happen to them. So the medical screening examination is a very fluid thing that sometimes is very quick and sometimes requires a lot more investigation. And it's up to each individual hospital to determine who exactly can do that. The pretty much standard across the country, although not written into law, is that the medical screening examination needs to happen by either a physician or nurse practitioner or physician assistant. They're the ones who are able to initiate that medical screening examination and then determine whether or not this emergency medical condition exists or not. So, like I just said, you have to have a qualified examiner. So that's got to be an advanced practice provider or a physician who's able to determine that emergency medical condition. So the hospital has an obligation to anybody that presents to the hospital. Anybody that presents to the hospital seeking out emergency care is obligated to have a medical screening examination. We're not allowed to delay their care to inquire about how they're going to pay for this or whether or not they've got insurance. If you've ever noticed, now that we're doing lots and lots of bedside registration, if one of the physicians or nurse practitioners or physician assistants walks into the room to examine the patient and the registration folks are still there, they will very quickly exit because they can't be seen as delaying care, to obtain any of the insurance information, et cetera, for us to do our medical screening examination. We also are required to post a sign that notifies patients of their right to a medical screening examination and treatment. And that's posted usually kind of inconspicuously in most places around the hospital. Is that, it usually says this hospital participates in Medicare or Medicaid, and here are some of your patient rights. So it may not be specific to the emergency department, but there may be more than one thing because there are also other rights that patients have when they're admitted or if they're here for outpatient things. So if, as part of this medical screening examination, we determine that an emergency medical condition does exist, we've then got to provide treatment until the condition is resolved or it's stabilized, or we have to provide for an appropriate transfer. So what that means is if you show up and you're having a heart attack, if I'm at a facility that has a cardiac cath lab, again, all is part of this EMTALA, and before talking about who's going to pay for this, et cetera, if you're having a heart attack, we're obligated to then treat you regardless of your ability to pay. So that means taking you to the cath lab. It means, if you're not going to be able to get an intervention in the cath lab and you need to have open heart surgery, by gosh, we're going to give you open heart surgery to get this resolved, or to stabilize things enough that we can, discharge you out of the hospital. Or if we've got something that we can't do. So another example is, we've got that same heart attack victim who is having a heart attack, and you're at a hospital that does not have a cath lab. Obviously, we can't provide the necessary care. So we're obligated to provide whatever care we can provide within our limitations, within our scope of practice, and arrange for an appropriate transfer. So what an appropriate transfer means is that you have to send the patient then to someplace that has the necessary specialty or necessary equipment, et cetera. And they've got to have an open bed to be able to take care of that patient. And they have to have a provider who is willing to accept that patient and transfer. So that's something that we run into every now and then is, we'll have a patient that needs a certain specialty. Behavioral health is a prime example. And we may not have availability because all of our beds are full. And so we'll start calling around to other places. And it may be that other places don't have any open beds either. So obviously those places are not under any obligation whatsoever to accept our patient because they're themselves full. And again, it's kind of up to each individual institution as to determine what their cutoff criteria is as far as whether or not they're still open to accept transfers, et cetera. Most places are pretty good about still saying yes to things, and that they'll work out coming up with an open bed by the time the patient gets there, or in some cases we'll end up transferring emergency department to emergency department so that at least the patient is over there where the specialist that they need or the equipment that they need is there to take care of them. But it really is kind of department and hospital systems specific as to what their criteria is for whether they're open or closed, as it were. So this is how I think all of us sometimes feel when we've got that train wreck patient in the back of the squad, and we're just happy to get them out. But we also have that feeling on the emergency department sometimes where we've got the train wreck of a patient that we need to get them out of the ER. They're consuming lots and lots and lots of resources, et cetera. And so we do our best to try and get them off and up to the floor or off to their final destination. So in order for us to transfer somebody, the patient's got to be stable. And what that means is that that's not stable overall. That's stable within our capabilities. So if somebody has something that I cannot fix, I have to do everything that it was within my power to fix that and stabilize it as much as I can in arranging for the transfer. We also have to have some sort of an expectation that there's not going to be any significant deterioration of the patient en route. So obviously, if somebody has breathing difficulties and is not doing well, and we need to transfer them to another facility, if there's any inclination that that patient's airway is going to go bad or that they're going to need to be intubated, then the physician is honestly responsible for determining whether or not that patient needs to be intubated before they leave in order to further stabilize the condition within their capabilities. As we talked about just a minute ago, we can transfer patients in an unstable situation when we believe that the medical benefits of the transfer outweigh the risks. Or the patient has made a transfer request in writing after being informed of the hospital's obligation to treat them. So if we have somebody who, again, going back to the heart attack victim, we've got somebody, we've done our best to stabilize them, but it's not going to fix the underlying problem. Essentially, we have to document that the benefits of transferring this patient so that they can get a cath lab procedure performed outweigh the risks of the transport, whether it be deterioration en route, death, airway collapse, cardiac arrest, things like that we have to have a reasonable expectation that the benefits of getting to the cath lab are higher than that of the risks. The patient, regardless of whether they're stable or not, can ask that the hospital transfer them. And this is where it gets a little gray because it doesn't happen all that often where you'll have a patient who's unstable and says, don't touch me, don't do anything to me, I don't want to be here, I want you basically to stabilize me, and even though you've got the capability of taking care of it, my surgeon, my heart doctor, my lung doctor, my whatever, only goes to XYZ hospital. So I want to go to XYZ hospital. So in a situation like that, we technically are obligated to transfer the patient. And even if they are unstable, the patient may say, look, I get that I'm unstable. I don't care. I don't want you guys to stabilize me. I want you to get me to XYZ hospital. And so in that situation, then we get them to XYZ hospital, hopefully. So the transferring hospital, meaning the place where the patient currently is at, has to stabilize and treat within their capabilities. And whenever we're arranging for this transfer, the hospital that ultimately accepts the patient has to have the space to take care of that patient, and they've got to have the qualified personnel to treat the condition. And we've got to have a physician on the other end, or nurse practitioner, physician assistant, nurse midwife, whomever is qualified, accepting that transfer. We can't just simply say, oh, I know that XYZ hospital has a cath lab, I'm just going to send the patient there. We can't just simply call an ambulance and send the patient to XYZ hospital. We have to call over there, make sure that XYZ hospital indeed has the cath lab, that they have the cardiologist on call who can take the person to the cath lab, etc. Whenever we're sending the patient from point A to point B, we've got to provide copies of the medical record to the receiving hospital. In the greater Cincinnati area, it's not as big of a deal since everybody is on Epic for electronic charting. And so for the most part, we can see everybody else's stuff electronically. The practice, though, is still, if you're transferring outside of your healthcare system, to still print, the emergency department chart, because sometimes the connection between the hospital systems takes a little bit of time to update, and the current up-to-date information may not be accessible to the other hospital. That also includes any X-rays or lab work, etc. That's all got to be sent with the patient too. So what are the consequences if we violate this law? Well, there's increased liability. So, at the hospital level, if we transfer somebody who's unstable and we haven't done everything within our power to stabilize them and they crash and burn, we're liable for that. The physician who sends that patient from point A to point B is liable for that patient until they get to point B. And I think a lot of people forget that they're still on the hook until that patient actually reaches where they're being transferred to. A lot of the time they just focus so much on, well, they're out of the hospital now, they're no longer my problem. Well, technically they are your problem until they get to where they're trying to get to. There's also liability for EMS. If we bring a patient to a facility, that facility is super busy, and we turn around and walk out, and that patient then crumps on us while we're on our way to another hospital, we're on the hook for that. We're liable for that because we've broken EMTALA. The patient didn't get a medical screening examination, an appropriate transfer wasn't arranged, et cetera. And so it really does place a lot of liability, not only on you as the provider, but also on your department. So as far as the hospital level stuff goes, it's a pretty hefty fine. It's $50,000 per violation to the hospital, and it's a $50,000 per violation to the physician or physician assistant or nurse practitioner or whatever. And that's not paid for by liability insurance. So that's you. You are on the hook for that much. It also places your Medicare or Medicaid enrollment in jeopardy. So both the hospital and the physician could be suspended from participating in this program. You may even, if it's becoming a recurring theme, be barred from future participation, meaning, you may get suspended initially, but if it's a pattern, they may say you're never allowed to participate in Medicare or Medicaid, which essentially means your hospital's now out of business. Hospitals cannot survive, providing a broad range of services if they don't accept Medicare, Medicaid. In addition, the receiving hospital can sue for damages as a consequence of that transfer. So, if we send somebody inappropriately, the hospital that gets them can say, well, wait a minute, you sent this patient over, you had the capability of treating this, the patient didn't want to leave your hospital, we ended up having to do, some major surgery on them that you were capable of performing. We're not going to get reimbursed for that. So we're going to go after you as the hospital to reimburse us for that because the patient initially presented to you. And so you should be on the hook for whatever costs were incurred. Same kind of thing can apply to EMS. So EMTALA doesn't require us to do a bunch of different things. So if it's a non-emergency medical condition, then we don't have to deal with it. So somebody that comes in and says, I need a work physical, that's not an emergency medical condition. And so we're not obligated to perform that for them. If they come in and they say, hey, I want to be vaccinated for something, that's not an emergency medical condition. Somebody that says, I just want to get my vital signs checked, but I don't want to get evaluated. That's, again, not a requirement to do the medical screening examination. We're also not expected to provide treatment that's beyond our hospitals or physicians' capabilities. So, if we have something that we're not capable of treating, the feds are not expecting us to suddenly learn how to treat that condition or get the equipment to treat that condition, just so that we don't violate EMTALA. So if it's beyond our capability, then we're fine. EMTALA doesn't require us to go above and beyond. Same thing with scope of practice or the standard of care. And that's where some lawsuits kind of get hung up is did this meet the standard of care? Did we do everything that we reasonably could have to stabilize out this medical condition? We then have to treat and stabilize non-emergency we don't have to treat and stabilize non-emergency patients. So once we've determined that this patient no longer has an emergency medical condition, we're under no obligation at that point to provide additional treatment and stabilization of them. So again, going back to kind of the sore throat thing, somebody comes in, they have a sore throat. We do a medical exam on them, determine that this is, not an emergency medical condition. This is just a viral infection, etc. At that point, we've determined that it's a non-emergency and we don't have to provide any additional treatment. So we're not obligated to start them on medications for this, etc. So some hospitals in the past have really tried to put somebody out at triage. Like there are several hospital systems out in Texas that have put providers out at triage, and essentially with the hope of, somebody comes in with the chief complaint, they take a look at the patient, go, yep, that's not an emergency. You want to be seen, it's $300 up front. And if the patient says, no, I'm not going to pay that, then they say, okay, there's the door. We've done our medical screening examination and determined that you don't have an emergency medical condition, and therefore our obligation to you has ended. EMTALA no longer applies also if the patient's been stabilized. So if we've taken care of the patient and they're now stable, etc., EMTALA no longer applies, or the patient arrives at another hospital. The EMTALA obligation from the originating hospital has been fulfilled at that point. So let's talk about some specific situations regarding this. So let's say we have a patient that is at the loading dock and is unloading some stuff from a truck and begins to develop chest pain up in their truck. And they call out to a staff member that's there and they say, hey, I'm having chest pain, I need help. Does EMTALA apply? And the answer is yes. They're on hospital property, and they're asking for help from a staff member, who then has to notify the appropriate emergency response, protocol, so that way the patient, or now existing patient that used to be somebody just delivering something, the patient has to have a medical screening exam and whatever treatment might be needed. And it's a gray area as well. Let's say that this patient is up in a truck and we don't have the capability as a hospital of getting that patient up and out of that truck. It may be that we have to call our partners with EMS, because they do have the equipment to get that person out of their truck. We still have an EMTALA obligation to render whatever aid we can within our capabilities, but we are also permitted to call for help when we need it. So we call for help because we already have an established relationship, and this is an EMTALA applying situation. That ambulance would then need to essentially transfer care back to the hospital once they had gotten that patient out of the truck and maybe onto a hospital gurney at that point. What about if we have somebody who is found in the bushes outside the emergency department? Yes, EMTALA applies here. If we get notified that there's somebody outside and we're at a hospital that has an emergency department, we're obligated to render whatever care we can. Now, we don't have to put ourselves in danger. We don't have to do things, again, that are outside of our scope of practice, etc. But we are obligated to do whatever care we need to. So if the scene isn't safe and we need to wait for the police to get there to secure the scene, etc., then EMTALA doesn't require us to go barging in on an unsafe situation. But it does require us to do whatever we can to minimize harm to that patient. And then once the situation is settled, getting that patient the necessary medical screening examination, as well as whatever treatment they need to stabilize things. What about park across the street? So let's say we have a gunshot victim who gets dropped across the street from the emergency department. Well, they're not on hospital property, right? The hospital's not necessarily on the hook, right? No, the hospital is on the hook. So anybody who presents within 200 yards of the hospital property has to be seen if they're presenting with an emergency medical condition. So let's say the patient gets dropped off across the street in a park, and one of their friends either calls the hospital and notifies them that they dropped them off over there, or we have somebody standing out, by the ambulance entrance smoking a cigarette, who's a staff member who sees this guy get dropped off. That's essentially our notification that we have a patient. Even though they're not physically on the hospital property, they're within 200 yards of it. And so we are obligated to provide whatever stabilizing care we can. It may be that because this is a gunshot victim, that our policy says, look, it's a gunshot victim. We're not going to go barging into this until the police have secured the scene. Again, that's fine. EMTALA in that situation doesn't apply. However, it does apply as soon as the police arrive and have secured the scene, and we now have the capability of taking care of that patient. So it's very important that if you're ever at a hospital, etc., and somebody presents and says that they're having an emergency, etc., even if they're not physically on hospital property yet, that still is an EMTALA related complaint as long as they're within 200 yards of the hospital property. So let's say we have an OB patient who presented to labor and delivery. Well, labor and delivery is not part of the emergency department, right? Therefore, it's not an emergency, right? No. Basically, if you have a triage screening area as part of your labor and delivery area, anybody who shows up to that area and says, hey, I need treatment, essentially EMTALA views that obstetrical triage area as part of the emergency department, even though they're physically located in different spots. And the same thing happens with other specialty line services, such as psychiatric emergency services, or if you have a dedicated chest pain center, etc., then those would be viewed as having being extensions of the emergency department if they accepted patients that were coming in, with undifferentiated complaints, etc. So yes, the hospital is still on the hook for that patient. They still have to, provide whatever stabilizing treatment. And again, if somebody shows up to labor and delivery and says, hey, I've got a sprained ankle, I want care, even though they're presenting to labor and delivery, the hospital still has an obligation under EMTALA to get them down to the proper emergency department so that they can have their medical screening examination and whatever necessary stabilizing treatment. So let's say an OB patient presents to the emergency department and we don't have obstetrical capabilities. Well, guess what? We have to do whatever we can that's within our scope of practice, which is exactly why I've delivered 2 kids at Mercy Claremont and 1 kid at Mercy Mount Orab. If you have somebody who shows up in labor and you don't believe that you're going to be able to get this patient transferred to a hospital that does have obstetrics capability, guess what? As an emergency physician, I am credentialed to provide delivery services and perimortem C-section. So if I'm delivering this kid and I run into problems and the kid is only going to be able to come out by C-section, I'm not necessarily credentialed to do that. So I am not necessarily liable under EMTALA to perform a C-section on somebody who's alive and awake. I'm only credentialed to perform a C-section on somebody who's essentially pulseless, apneic, with CPR ongoing in an attempt to save baby or mom. So I've done what I can within my scope of practice and within my capabilities to stabilize that patient as much as I can, and then get that patient transferred to a place that can do the procedure that they need, has the necessary resources to take care of them. What about a AAA patient? So at Mercy Claremont, we also don't have vascular coverage. So what am I supposed to do with a AAA patient who is rupturing that presents to the Claremont Emergency Department? Well, I'm obligated to, one, see the patient, two, do whatever testing is necessary to determine whether or not an emergency medical condition exists, which in this case hopefully includes a CT angiogram, so that I can take a look at their blood vessels, determine that this is actually a AAA rupture, and then if that's the case, arrange for their fast transfer to a place that can treat that rupturing AAA. In addition, I've got blood. So if this patient needs to have blood administered to them, I'm obligated to provide them with whatever stabilizing treatment I can that's within my scope. So I'm obligated to provide this patient with blood, pain medication, if they're on Coumadin, reverse it, things of that nature. I'm not expected to fix the AAA because I don't have that capability. So what about EMS diversion? So we've got a hospital that goes on diversion, but EMS brings the patient there anyways. Can the hospital refuse to take that patient? And the answer is no. The hospital has an obligation to see that patient even if they're on diversion. There is no caveat built into EMTALA for when hospitals are at capacity. If an ambulance shows up, it is the same as a patient walking in the front door. We're not allowed to lock the front door to the hospital and say, nope, we're full, you're not allowed to come here. We still are obligated to do whatever is within our power to evaluate that patient and provide whatever stabilizing treatment is needed. So even though the staff may not be happy with you, under the law, they are still obligated to see that patient, perform a medical screening examination, and then provide whatever stabilizing treatment is necessary. And then if they truly can't take care of it, arrange for that appropriate transfer. So let's say that we have a helicopter pad at the hospital, and we want to use it as EMS to fly a trauma victim out from our local emergency department to a trauma center. If the patient goes on hospital property, aren't they covered by EMTALA? Don't we have to go into the hospital? Even though EMS knows that place doesn't have that capability, but we just want to use the helipad, are we obligated to go inside the hospital so that they can get evaluated and screened before we're allowed to use that helipad? And the answer is no. There's actually a carve out for this. So if EMS determines that they have something that requires the use of a helicopter, and the local hospital doesn't have what that patient ultimately is going to need, like say a cath lab or trauma surgeon, etc., as long as EMS goes to the helipad directly and does not stop in the emergency department, then that is not an EMTALA violation. The hospital has never been informed that there was an emergency patient there. And the hospital has not been asked to provide any services. Now, the couple of carve-outs from this are, let's say somebody sees that there's an ambulance that's going to sit by the helipad. They get notified that such and such ambulance is going to be rendezvousing with the helicopter at our helipad. If we send somebody out to say, hey, how you guys doing? Unfortunately, EMTALA then applies. That patient then has to get evaluated because now the hospital has made contact with that patient and has to have a medical screening exam performed, whatever necessary stabilizing treatment before the transfer, and then arranging for the appropriate transfer. So that's why it's really important that hospital staff stay inside, unless they are specifically asked to go outside and assist. If they're asked to go outside and assist, then EMTALA applies, and they're obligated to go out there and do what they can within their power. So keep that in mind, that you can use the helipad at hospitals without violating EMTALA. What about if there's too much work? So let's say we've got an on-call specialist who doesn't want to care for that patient. They say, oh, no, those kinds of patients, have really bad complication risks. I just don't want to deal with the headaches of that. Or, I'm getting ready to go on vacation. I'm not going to, be able to follow up on this. And I really don't want my partner to have to follow up on this. So no, you better just send that patient to another hospital. No, EMTALA does apply there. the on-call specialist who's capable of treating that is, again, obligated to perform whatever stabilizing treatment is necessary for that condition. And so it may be that they don't want to take care of it, but if they're capable of taking care of it, by God, they've got to take care of it. It may be that they don't want their partner to have to follow up on this difficult patient, but that's not a reason that we can use to transfer the patient. Say if there's a specific type of equipment that the surgeon needs, or there's a specific type of subspecialist that is needed to take care of this patient, that's different. We've, again, outstripped our capabilities, and so we need to transfer them to somebody who can meet that need. What about if your on-call specialist has been up all night, taking care of, say, a ruptured AAA? They get done and they get called and are told, hey, guess what, doc? Today's AAA day, and you just got another one that came in. And the physician says, look, I've been up all night long. I'm exhausted. I don't think it's safe for me to take care of this patient because of how tired I am. Is that an EMTALA violation? And indeed, that is a carve-out. The patient is not obligated to be seen by that on-call provider because they've said, look, I'm too tired. I've been up all night. I've been in a case. I'm too fatigued. I think that this is not a safe transfer for the patient, or not a safe thing for the patient to remain here under my care. They really need to go to a different facility that has somebody who is more awake, more alert, better able to care for this patient currently. That is permitted. That being said, the hospital that is sending the patient to a different hospital had better document very thoroughly why the patient is being sent from a facility that theoretically has the capability that the patient needed to a different facility, because the other facility, if they choose to make an issue out of it, could, and you need to be able to have the documentation there to say, well, yeah, technically we do have that capability, but our surgeon was up all night and couldn't safely render the care that was needed. If 3 years down the road that kind of stuff isn't documented, then it may end poorly for the hospital and the doc who said no, because they're not necessarily going to remember that particular night they were exhausted and couldn't safely care for that patient. So what about we don't have anybody on call? So let's say we have one hand surgeon, and we typically have coverage. But the hand surgeon takes a 2-week vacation to Aspen. We don't have that capability then. So EMTALA doesn't apply in that situation. We're allowed to transfer that patient. And unfortunately, from the emergency department, we run into this all the time. Yes, we may have a subspecialty person on the medical staff, but they're not the person who's on call. And sometimes the subspecialists at other facilities will try and make a stink over this, saying, well, wait a minute, you have this capability, and we're not going to take this. You just need to call the person who's not on call and have them come in and take care of it. Well, as long as the person is not on call or is out of town and we temporarily don't have that capability, then that other hospital is still obligated to take care of that patient. We don't have that capability. We've done everything within our power to take care of it. And so that other hospital has to accept that transfer as long as they have the bed and the necessary stuff to take care of that patient. So helicopter. So you want to transfer the patient to a different facility, but they say that they will only accept the patient if you use their helicopter. That's an EMTALA violation. The facility that is accepting the patient cannot make accepting the patient contingent upon other things. It's either yes or it's no. So it is up to the hospital that is sending the patient and that qualified examiner as to how the patient gets from point A to point B. And the receiving hospital cannot dictate how that person is going to go. It's still the responsibility of the qualified medical examiner at the original hospital to determine this is what the patient needs, this is how it needs to be rendered, et cetera, et cetera, et cetera. And unfortunately, we see this, or we used to at least see this more frequently with helicopter services. One hospital would have their own helicopter and another hospital would have their own helicopter. And, the hospital that's accepting the transfer would say, well, we're going to send our helicopter over to take this patient there because they wanted the helicopter billing. And, they would try and say, well, if you're not going to use our helicopter, we're not going to accept this patient. And they don't have the authority to do that. It's up to the medical examiner at the original facility to determine how that patient is going to get from point A to point B, and what mode they're going to use and what resources are needed to facilitate that transfer. All right, so let's say the emergency department is too busy. You walk in, you're an EMS provider, you walk in to transfer care since you took the patient to a hospital, and there are 3 other squads ahead of you. Does EMTALA apply here? Can't I just turn around and walk out? I haven't registered the patient. I haven't, told anybody that I'm even here. Can't I just turn around and walk out? They're still my patient, right? No, unfortunately, EMTALA still applies here. So even though you may look at this and go, boy, this place is really busy. I know that the hospital down the road isn't busy. Maybe the patient will get seen faster by going to this other facility. Unfortunately, as soon as you enter the hospital property and bring that patient to the emergency department, the hospital has an obligation to provide a medical screening examination and whatever stabilizing treatment is needed. And then if they don't have that capability, transfer the patient. So even though the hospital may not have even known about your presence, if you show up at a hospital, document that you showed up there, et cetera, et cetera, et cetera, the hospital is still on the hook for that. It also really increases your liability as an EMS provider as well, because you've taken this patient to a hospital. You did not get them evaluated. You did not facilitate their transfer, et cetera. Instead, you picked them back up and walked back out the door to go to a different hospital. If that patient begins to deteriorate between point A and point B, you may be on the hook for that. And remember that liability insurance doesn't necessarily, provide protection for these kinds of things. And so you may be left on the hook for either the fine or, adverse event, kind of thing. So I know that was a lot of information to go through in a relatively short period of time. Again, when I do this lecture live, usually there's a lot more back and forth, discussion, etc. But I still think there's value in you guys knowing about EMTALA and knowing why things are the way they are, and why we sometimes are so specific about how patients get moved and transferred and that kind of thing. Again, the QR code that you see up on your screen will load my contact information into your phone, so scan away with your phone. If you've got any questions, feel free to email me or text me or call my cell phone. Again, thank you for everything you do, and stay safe.